Thank you, Kim and Emily. I know that both of them were going to be joining the symposium at various points today during their breaks, so I don't know if they're here with us now, but if you are, thank you very much for sending in that video. Kim mentioned, of course, the importance of using screeners, and this is a large focus of the Ontario Human Rights Commission's Right to Read report. It was the second benchmark in the report, and there's an entire section in the report discussing the necessity of using those screening tools. And I'm very excited that our next guest and speaker is joining us today, Dr. Nadine Gaab. She is a world-renowned expert in screening. Dr. Gaab is an associate professor of education at Harvard University. Her work focuses on typical and atypical learning trajectories from infancy to adolescence, with a special emphasis on language and reading development and the role of the environment in shaping these trajectories. Her work is at the intersection of developmental psychology, learning sciences, neuroscience, ed tech, and educational policy within a learning disability framework. Her research laboratory employs longitudinal behavioral and neuroimaging studies to characterize differences in learning as a complex outcome of cumulative risk and protective factors interacting within and across genetic, neurobiological, cognitive, and environmental levels from infancy to adolescence. Her theoretical work focuses on multifactorial frameworks of learning differences with an emphasis on early identification and preventative education. One important key aspect of her work is the translation of research findings to address contemporary challenges in educational practice and policy, with a special focus on screening for dyslexia and early literacy milestones. Welcome, Dr. Gaab, and thank you so much for taking the time to join us today.
Thank you so much for having me. I put the handouts to today's presentation in the chat, so you can download it and let me know if there's any problems with this. I'm gonna now share my screen. Is that correct, Alicia? Okay. All right, could someone give me a thumbs up if you can see my, okay, great, thank you so much. All right, yeah, I'm very honored to be part of today's day. What an important day, and thank you so much for the organizers for putting this important symposium and day together. I wanted today talk about moving from a reactive to a proactive model in education and give you like a little bit of a ride through the neurobiology of how we learn to read, early identification, and then we will conclude with some very practical screening strategies. So we're not going to focus on the entire report, but really focus on the early identification and the screening, and how could that actually look like in Canadian schools and schools in Ontario. What I would like to start with is to say that learning to read is not a natural process, right? Learning to read is a process that requires the mastering of a series of developmental milestones in response to the input from the environment, starting with language processing and ending with proficient reading many years later. So it's not like putting a child in the library and surrounding them by rich books full of wonderful stories will automatically produce a reader, right? It's more like learning a musical instrument, right? So you could listen to, Mozart all your life, but if I would put you in front of a piano and ask you to actually play the piece you have been listening to for many, many years, you will not be able to do it without explicit instruction, right? So learning to read is not a natural process where, like language, if you're immersed and exposed to it, it will automatically happen. So it's what we call an explicit dependent, experience dependent skill. So it needs experience and instruction from the environment. So if you ask people, when does reading development starts? I bet you get 50, 60 different answers. You should try it with your colleagues or your friends or your family. Some people say, well, it starts the first day of kindergarten, or right when we start formal instruction. Some say, no. It starts when, we start, identifying letters or teaching letters. But if you think about it, the fundamental milestones of learning to read are oral language and sound processing, right? The sounds of our language, the units of our language. And this is happening as early as in utero. So I like to really shift our focus from, let's, just, think kids are, clean slate in terms of reading development until they come with their little backpacks to the first day of formal reading instruction, to really thinking about it as a developmental process that starts as early as in utero, or it does start in utero, right? And then if you go along the developmental timeline that you can see here, is that from this exposure in utero, there is, rich emergence in oral language, rich learning of the syntax of the language, the sounds of the language, the vocabulary, the usage, right? And so the first 4 years of reading development, as I see it, is oral language development. Right? So we have to keep that in mind when we think about early identification, if we think about screening, that we are not starting the first day formal reading instruction starts. The kids are coming with those rich experiences. And then, once they start mapping these sounds of the language or languages onto the graphemes, and then start to decode small words or short, words, and then start to decode sentences. And the ultimate goal of learning to read is read with great automaticity, prosody, as well as understanding, comprehending what you read. So you can see what a complex process learning to read is, and that we need explicit instruction from the outside, and that it starts, in utero. What's also important to keep in mind that there is a shift from learning to read to reading to learn, and that usually, depending on the school districts happens around the end of second, beginning of third grade, right? Where teachers often stop explicitly instructing how to read, and they then just utilize reading to convey knowledge, to give word problems in math, to give instructions on an exam, to convey information about homework. So if you're not reading when that shift happens, and you're not comfortable and automatic in your reading, it will have tremendous implications beyond just ELA, beyond just English language instruction or whatever instruction you're learning to read in. I'm sure you've seen this before, probably even today. And so what's really important to keep in mind in this journey of how do we learn to read is that there's two important strands, right, for successful reading development. One is what I often call the mechanics of reading. So it's really like, how does it actually work to translate these graphemes into sound units, and merging these sound units to meaningful words that are represented by the graphemes. The word recognition piece, or the mechanics of reading, becomes increasingly automatic, and it contains the ability to manipulate the sounds of language that we've been learning since being in utero. So phonological awareness, decoding, side word recognition, and with side words we mean words that you just recognize by looking at them, not because you're exposed to lists of words that are spelled in a way that you want to just learn by sight. Sight words are words that are you just look at them, what they are, and you increase your sight word repertoire by becoming increasingly automatic. But you can be the best decoder if you don't understand, if you don't comprehend the words that you decode, it's kind of useless, right? So the same for the grammatical structures, right? So you could be a really good decoder. You could be really good in understanding, having a good vocabulary, the words you decode. But if you, let's say, have been exposed to very short sentences, or you're not have been exposed to English sentences at all, then you may encounter problems where you are decoding a long sentence and you don't understand how the end of the sentence relates to the beginning of the sentence, because you've never seen a sentence structure like this before. And that will really influence your reading fluency and your reading comprehension. So I hope you understand from utero all the way to successful reading acquisition. We have to somehow have these two strengths that are with the language strength starting way earlier, and then the word recognition strength becoming important, and creating this this woven cord of reading. The development of basic reading skills is one of the primary goals of elementary education. Here in the US, where I'm based, 65% of fourth graders are reading below grade level, and approximately 80% of those coming from low socioeconomic backgrounds are reading below grade level. This has tremendous implications for their mental health, right? How you feel about being a learner, how motivated you are to learn to read, but to learn in general. We see that difficulty with learning to read can lead to low self-esteem very early on, feelings of shame, and we see the struggling readers as being at a greater risk for developing internalizing symptoms or externalizing behavioral problems, right? And it makes a lot of sense that if you hate reading instruction because you just can't figure it out and it's really frustrating to you, you may act up, you may become the class clown, you may throw something because of the frustrations and the inability to control these emotions because you're still working on social emotional development. If you look at adolescents and adult outcomes, children with learning disabilities are less likely to complete high school or enroll in post-secondary educational programs. And there's tremendous implication on their economic, but also on their mental health or general health outcomes because of your struggle with learning to read. So how does reading improve learning, or is related to learning? So on average, we think that a kindergartner starts the first day of kindergarten, so the first day of formal reading instruction, with maybe a vocabulary around 10,000 words. So they understand the meaning of around 10,000 words. And by fifth grade, that goes all the way to 60,000. So that's about 250 words per week. We also know from research that that increase is to a large degree due to reading. And it doesn't have to be like reading Harry Potter. It can be just reading the signs on the bus. It can be reading the instruction of your video games or the back of your cereal box. So what we do know is that students at the 90th percentile, so really good students, only 10% read better, may read as many words in 3 days outside of school as a child at the 10th percentile reads in an entire year outside of school. So you can see how super quickly, struggling to learn to read, combined with the frustration and the lack of motivation because it's so hard, can lead to fewer vocabulary, reduced exposure to sentence structure, etc. We know that 70% of below average readers in first grade remain below average readers in eighth grade. And children with reading difficulties in third grade are likely to struggle throughout their entire educational career if they don't receive help. We also know that struggling readers are 4 times more likely to drop out of school, and African American and Latinx children who are struggling readers are twice as likely than their white peers to drop out before high school. So what are the factors contributing to atypical reading development? So we have genetics, we have brain, perception, and cognition environment. And we used to think many years ago, maybe it's just one factor, maybe it's a combination of two. And now the research has shown that it's for every individual child, a combination of many different factors. And we need to have a multifactorial model where we tease apart these factors and try to see which ones are important and which ones are important for this child, and develop screening strategies and early identification strategies, taking those into account. So we see reading disability as an umbrella, where dyslexia is under the umbrella, and we'll talk about this in the next slide. But also you can have reading difficulty as a result of environmental circumstances, right? Less exposure during the first, years of oral language. So you may start with reduced vocabulary, you may start with, reduced listening comprehension, which then will influence reading fluency and comprehension. You can have an expressive or receptive language delay, which then all can lead to various aspects of reading problems, including dyslexia. So dyslexia affects about 7 to 10% of children, and it's a specific learning disability with the neurobiological origin, we'll get to this, characterized by difficulties with accurate or fluent word reading. And so we talked about these mechanics versus oral language strengths in successful reading acquisition. And so dyslexia is really a problem with the mechanics of learning to read, right? So subsequently, that can lead to problems with reading fluency and comprehension, but the core deficit is in this word acquisition, this mechanics of reading. So if we look at the reading network in the brain, we have a network that is comprised of many different areas. Today I'm going to just talk about some of the most important ones, and they're in the left hemisphere, right? So you're the left brain here with the colored dots here. This is the left side of your brain, and you see in red an area that we call the visual word form area, or the letterbox of the brain. And it's a really interesting area because it actually develops in response to instruction. So it's not developing in children or adults who have not received any reading instruction, and it can still develop in your 50s if you start learning to read then. And we have the orange part here, which is a language processing module in the brain. And then in green, we have an area that maps the sounds of our language system onto these graphemes. So early on, we have this sort of triangle here in the back, which, between the red and the green and the orange. And that's why it's so important to, talk about, oral language as well as the instruction of the mechanics, so something like phonics, right? Because we need to make sure that the sounds are linked to the graphemes and the combination of graphemes. And then in purple here, you have what we often call the CEO of the reading network, because it does what the CEO does in a company. It focuses on the important parts, it integrates into the bigger picture, it's involved in reading fluency, reading comprehension, etc. On the right here, you see what we call, white matter tracts, but it's often better understood as the highways in the brain that enable information flow between the different brain areas. So if the letterbox needs to talk to the CEO of the reading network, that happens through information flow along these long axons here. I want to show you a quick video that illustrates, a brain learning to read. So this is an adult brain reading, but it shows you sequentially what brain areas are involved when you read. And what you can see is that it starts in this back here, the visual areas, or where the word form area is. Then it goes through these oral language areas. And then the last processing step is that CEO in the front. So there is no wonder with these complicated networks talking to each other versus, long, complicated highways that sometimes something can go wrong. So we know that there is structural and functional brain alterations in struggling readers. So we know that children who struggle or who have a dyslexia diagnosis may have, less gray matter. So it's the processing capacities of the neurons in some of these reading networks. We also know that, some of these highways, maybe, instead of 4 lanes, 2 lanes, or instead of really smooth surface, like a bumpy surface, like we call as myelin, that may be impacted. It may also not look like a highway, but a little bit more disorganized, which can disable information flow or make it much, much slower. So there's a lot of research that has been done that could show that, children who struggle with learning to read show, an atypical brain development. The question is, how early can we see this? And so my lab has done a lot of work starting in infancy, in toddlerhood, and preschool, and tracked children over many, many years to see, when are some of these alterations that we see in older children who struggle with reading emerge? Is it something that emerges, after you start exposure to formal reading instruction, or is it something that predates the onset of formal reading instruction? And that's a really important question for policy, right? So if the brain is, a clean slate in all children and it's all the same the day we start kindergarten, and it changes while you are struggling with learning to read, that's very different than, no, there's a group of children who will come and step into the first day of kindergarten with a less optimal brain for learning to read. And so that means we need to find them early and intervene early. And so we could show that some of these alterations predate the onset of reading instruction. We could see that some of them are, some of these alterations seem to, create a scaffold onto which it's harder and needs more work and more repetitions and more explicit instruction to learn to read. So this is especially interesting if you think about how early, can we see these alterations. And so a lot of brain development in its finest, or the really big changes in, white matter and the number of neurons and the number of highways and axons that connect, is happening in the first 3 years of life. So we started the Baby Bold study about 10 years ago, where we've been tracking children who have a strong familiar risk to develop problems with reading compared to children who did not have that strong familiar risk. So we know that if you have an older sibling or a parent with dyslexia, you have about a 40 to 60% chance to develop the dyslexia yourself. So this is very high compared to some of the other developmental disabilities. So you can see here, these babies are sleeping peacefully in our big brain camera, and then they come back every year. And so we see them and look at their brain development and their language and reading development. So this little girl here is actually my daughter, who is now 12, just finishing 6th grade. So you can see how long we've been doing this study. And you can see some of these highways in these babies, and then we can follow them longitudinally. So we could show that some of these alterations and these highways are there as early as infancy. And we could see that they seem to be, persistently there. If you look, this is a cross-sectional study, but we saw similar segments of these white matter tracts being different in infants versus pre-readers, beginning readers, and fluent readers. And we can also follow these kids then longitudinally, and we could just show that some of these alterations are prospectively associated with phonological awareness and vocabulary knowledge once they start kindergarten. So we believe that some of these alterations are already there as early as in infancy, creating a scaffold that may be less optimal for the traditional learning to read process, and needs really really good instruction and more of the good stuff to develop a good reading network. So let's look at some of the screening process. So this is from the US, but it's the nation's report card. And what's so striking about this is an assessment that's done every 2 years. And it's, this graph here started in 1992. And if on average children would be proficient at reading in 4th grade, you would see these little bubbles here up here where it says proficient. So when I said that 65% of children are not reading on grade level, this is what you see here. What's really shocking here is it hasn't changed, right? So there has been a lot of important policy implications, there's No Child Left Behind, IDA. There's a lot of changes in policy that were introduced in the US, but it hasn't really moved the needle yet. And so let's look at a little bit of why that may be. I also want to do a comparison between the US and Ontario. So here you can look at the PIRLS and the A-PIRLS results, and you can see that between 2001, 6, 11, and 16, there have been not the significant big differences between Ontario and the United States. And this is directly from the report, where we can, look at these EQAOs and see that, only 74% of grade 3 students meet the reading standard. But what is important is that only 62% met the standards unassisted, so without scribing or assistive technology. So when it comes to learning differences, what we often do is we are largely focused on a reactive deficit-driven wait to fail model, right? So we are having these kids come in with their little backpacks and we start instructing them. And then we sort of wait and see who's going to be struggling, who's going to be failing, right? Instead of developing a preventive approach where the first time we encounter these little brains, we say, okay, let's figure out who will most likely struggle with learning to read before we even start explicit instruction. So the dyslexia paradox that we published a couple of years ago is the paradox that a reading disability is generally diagnosed after the most effective intervention window. So we currently most often have a diagnosis or start a very intensive intervention after a couple of years of failing, where we know that the window for the most effective intervention is way, way earlier, right? So there's all this work showing that when at-risk beginning readers receive intensive instruction, 50 to 90% of these at-risk children reach the range of average reading ability, right? So you can prevent kids from struggling to learn to read by finding them early and then giving them what they need. Which is really good tier 1 instruction, and then some of these kids need more than this, more of the good stuff. So what are the early behavioral predictors of reading difficulties and dyslexia? So phonological awareness, or the ability to manipulate the sounds of language. So things like say the word banana without b. Pseudo-word repetition, which is non-verbal verbal short-term memory. So you say non-words and ask the child to repeat it. We have rapid amortized naming, really good predictor of reading fluency. Vocabulary, so going into this upper strand of the reading rope. We have letter knowledge, letter sound knowledge, and oral listening comprehension, as well as a familiar risk of dyslexia and a familiar risk or a history of language delay are also really good predictors. So how can we solve the dyslexia paradox? How could we finally move the needle where we could see an increase in these reading scores? So we believe that we need to replace the wait to fail approach with an early support model, right? And I want to use the example of for medicine of early screening for heart disease as a comparison. So you go to your primary care physician for your annual checkup. And they do like a test for high cholesterol, right? They see if you have high cholesterol, and unfortunately the test comes back and shows that your cholesterol levels are elevated. At that point, you're not diagnosed with heart disease, right? The doctor will sit down with you and say, you have an increased risk to develop heart disease. So we want to avoid you developing heart disease. We want to prevent the development of heart disease. So what we're going to do now is we're going to put preventive approaches in place so that you never develop heart disease. That could be exercise, change in diet, it could be medication. The ultimate goal here is that you are coming off the risk wagon, right? And you are developing, a healthy heart or maintaining a healthy heart. It's the same what idea here with screening. So you want to identify children early on who are more likely to develop problems with reading. So you do comprehensive early risk screening. And if you find a child that has an increased risk to develop dyslexia or other problems with reading, you are using evidence-based response to screening. And ideally, you will do this within very well-trained general educators, right? So the idea here is not to diagnose 4 and 5-year-olds with dyslexia. And the idea here is also not to get these kids all in special education, right? It's almost like all these kids are not, all these patients with elevated cholesterol are not seeing a cardiologist the next day, right? So it's like a preventive approach, and we embrace preventive medicine. For some reason, we have a much harder time to embrace preventive education. So if that all works well, you would have lower rates of dyslexia and reading disability diagnosis and improved reading outcome in children with the diagnosis. So even if they develop problems, they will be less severe. I want to also mention that some of these kids may need to go directly to special education because of the severity, right? So if you have really high cholesterol, it may be good to see a cardiologist, but not everyone who has elevated cholesterol, who needs to, work on their, preventing heart disease, needs to see a specialist. So what should early screening look like? We recommend 8 key characteristics when determining an optional screening battery. It has to be short. We're not doing a neuropsych assessment over 3 hours. Needs to be comprehensive. If you think about the reading rope, you want to make sure you screen for oral language, right? Because that's the fundamental milestones of learning to read. The first 4 or 5 years of reading development is oral language and the mechanics of reading. You can be resourceful and use existing assessments you already have in the district. It needs to be early. I hope we are clear about that. You need to include English as second language learners, dialect speakers, and there are some new approaches how to do this. You want to ask, is there a familiar risk? Because that adds another risk flag in that multifactorial model. You want to make sure you have evidence-based response to screening in place before you do the screening, right? You can screen the whole world. If you don't do anything in response to it, it's kind of useless. So if you look at the Ontario Right to Read Inquiry Report, some of the recommendations are really spot on what we just discussed, right? So you want to do screening on foundational skills and on word reading and screening as early as kindergarten. And you want to use these results of early screenings to identify children at risk of failing to learn to read. And you need professional development on how to react to these early screenings. And so in the US, we now have around 35 or more states that have these early risk screening as legislation. And so you can go to the National Center for Improving Literacy and look at this map and click on each state and see what kind of reading screening they have in place. I also highly recommend, we just published this 2 weeks ago, an overview about screening for early literacy milestones and reading disabilities, the why, when, whom, how, and where. I published this with my wonderful colleague, Professor Petcher from the Florida Center for Reading Research, that was published by the International Dyslexia Association. So let's look a little bit in the last 10 minutes into diagnosis versus screening and some practical tips. So screening for dyslexia is different from a diagnostic evaluation conducted to formally diagnose a child with having developmental dyslexia. So risk factors do not determine whether or not a child will for sure have dyslexia, but rather represent the probability that a child will develop dyslexia, almost like a probability that you develop heart disease if you have high cholesterol. A screening test cannot tell that a child will subsequently develop dyslexia, but it determines its likelihood. Also, it's important that you embrace that multifactorial model, right? So if you have high cholesterol and you are overweight and you have a familiar risk of heart disease, that gives you higher risk than if you just have elevated high cholesterol, maybe once in your lifetime. How can you find a good screening instrument? So one of a really good approach is go to the National Center on Intensive Intervention, and they have a tools chart. And so don't look at these tests here. I just did a screenshot of the first page, but you can look up specific screeners, and then you can look at their psychometric properties. So do they actually measure what they're supposed to measure? Are they reliable? Are they for kindergarten? Are they, really having good classification accuracy? So telling me who's at risk or who's not, or is everyone at risk based on it? So that will be a really good step. Also, we developed a list of all possible screener we could possibly find, and compare them in terms of how much do they cost? Are they digital versus in paper? Are they screening actually for all components or only for some? Are they rated by NCII, et cetera, et cetera? So that list you can find here. It's currently under maintenance. We hope maybe in the next 2-3 weeks we're done with it and it's open again. But that's another resource. Another one is the National Center on Improving Literacy. We developed this, little booklet. I think it's 70, 80 pages, so maybe not so little, but that gives an overview about, the screening for dyslexia. Also, some other important factors to consider when selecting a screener is, look at how reliable it is. And you can find these in the manuals or ask the vendors or look at the National Center for Improving Literacy. How valid is it? Is it actually measure what it's supposed to measure? How representative is the sample? Is this maybe normed in, 30, middle-class white children from the UK, or is it representing the district I have, the children I serve in my community? And how good is it in actually determining who is at true risk and who is truly not at risk? I also want to refer you to the Massachusetts Dyslexia Guidelines because I think they did a really great job writing these guidelines. So if, Canada or Ontario is starting to look into this, then maybe a really good start. They give really good tips on how to establish a screening team, who should be part of the screening team, who needs to learn about this, who needs to be educated, how important is it to have different stakeholders, including caregivers and educators, educators and administrators on that team. It also gives a good overview on how can this be integrated with, progress monitoring and middle of the year benchmarks and other, maybe instruments that you are currently using or will be using in the future. I also want to mention Early Bird. So I have the conflict of interest here. I'm a co-founder and scientific advisor, but Early Bird is a game that you can play on any tablet or now also using your browser. And it screens for all important literacy milestones that we discussed. It's about 15 to 20 minutes. It is auto-scored. The kids just sit, play the game, and the educator gets a very rich dashboard learning who's at risk for which subcomponent, and it also gives you a platform with videos and curriculum and activities on what to do and where to find additional resources and professional development. So the question is, would all this idea of like the moving from a reactive to a proactive model actually move the needle in terms of improving reading scores? And it has been shown by Louisa Moats or UCAT that if you screen and you then provide evidence-based response to screening, that the outcomes are much better. So other screening challenges that you may want to keep in mind is you need to really work with all stakeholders that they understand what is screening and what is it not, right? That includes the parents where, screening doesn't mean I'm going to diagnose your child today with dyslexia and maybe she has it, maybe she doesn't have it, right? This is a screening. So using like analogies like the high cholesterol, or there's a couple other tooth decay prevention, etc., that can be really helpful here. Also, you want to really convey to your special educator that this is not overcrowding special education. It's actually supposed to do the exact opposite, right? It's supposed to like filter the children and do early prevention and only refer the kids who really need the special education help after the early intervention piece in the process. Like I said, there needs to be a plan for implementation that involves all stakeholders, and stakeholders all need to understand that screening is different from a diagnostic evaluation. Also, it's important that you spend a significant amount of time to select the right screener and develop guidelines, and establish and implement a good screening protocol. So there's great implementation loops that you can work with, see what works this time, what doesn't work, and really spend a good amount of time and thoughts on this. You need data literate individuals in your district or school, right? So if you pick a screener, and there's many great ones, that doesn't do the interpretation for you, you need someone who can actually look at the data and make inferences from the data. You need to really plan how do we respond to screening, look at the costs, and really think about the relationship between screening for early literacy milestone and screening for risk for dyslexia. So what are we actually screening for? Are you screening for the mechanics? Are we screening for reading comprehension? Because if you're screening for reading comprehension, it may not pick up kids who struggle with the mechanics. So there's a lot of thoughts that needs to go into this. What's important to keep in mind is there are now a couple of very cheap screeners out there that seem like the best super quick solution, but a lot of those are not directly measuring the child's ability. So they're just asking the teacher or the parent even, like, can your child do this? Do you think Johnny can do this? And they can lead to really bad biases, right? So just assume, and that these biases can be implicit. The kindergarten teacher is, stressed. The school's just started in the fall. You have, 25 new kids, and then there's this screening survey put in front of you, and it says, "Does little Johnny know all his letters?" And you're like, "Shoot, I don't know. I just got, met little Johnny, but his parents are these professors from down the street, and he went to this really fancy preschool, so I think he knows all his letters," right? So you can see how super quickly, also implicit, a bias can be created, and that can also go the other way around, where you think a child may for sure not know his or her their letters, but they do. The screener needs to match the student population, so you want to make sure that if you select a good screener, that it matches the student population in your district. And you need to also think about personnel, who's going to do the screening, who's going to interpret the screening. And we need to also think about the history of the child. So what is the oral language history? Is there familiar history? Is there an older brother who struggled with reading? What is the environmental considerations that feed into this multifactorial model? So where should we screen? So of course in schools, but we don't need to just, think about schools. We can think a little bit more outside of the box, right? So how about our well visits, pediatricians' offices? And I'll get to this in a sec, but it could be in preschools, it could be in libraries. So we just started a partnership where we are trying to see, can we maybe screen every Saturday in a local library and then link the results to book recommendations? It could be in clinical offices like SLPs, it could be in museums, summer camps, etc. So we just published this 2 years ago. It's a practical guide for pediatricians, how they could implement early identification in the pediatric practice for learning disabilities. They are currently screening most of them for autism and ADHD because these learning differences require medical interventions often, but they are not screening for reading difficulties or math difficulties. But given the high relationship with poor mental health outcomes and anxiety rates, etc., we think it's time to do short screeners that could maybe then refer to longer ones in the pediatric office. We also just wrote a paper on the screening in the context of social work. So that may be also important because often a social worker is like someone who is in the home and can, maybe see that some of the behavioral challenges a child has may be related to some of the, struggles they have in the academic setting. So to conclude, we have genetic factors and brain level and perceptual and cognitive factors, as well as environmental factors. And all of those factors over the time course of developmental progression from prenatal all the way to postnatal can lead to typical or atypical reading performance, right? So we need to really move away from the only cause of a struggling reader is X, right? Bad instruction or poor phonological awareness, et cetera, et cetera. No, it's a combination and the multifactorial place. And we also need to keep in mind things like stress with maybe immigration, stress with COVID related, stress because of low socioeconomic backgrounds, neighborhood factors, trauma, etc., that can also feed in. So the development of reading proficiency is a public health issue. Every child has the right to learn to read well. The right to equal education includes the right to read. I got this from the report directly. And literacy is a widely recognized determinant of health outcomes. It is associated with many indices of economic, social, vocational, academic, mental health outcomes and successes. the National Academy of Medicine recently highlighted the duration of education, which is highly dependent on reading proficiency, is a significant predictor of health and longevity, almost as significant or maybe as significant as cigarette smoking and obesity. So we need to make sure that, you know, we maximize the joy of learning to read and all work together to help kids to become happy and healthy readers. Thank you very much, and I'm happy to answer some questions.
Thank you, Dr. Gaab. So we do have a lot of questions, and one of them quite interesting. Well, they're all interesting. Thank you so much, everyone, for the questions. One addresses autism. Now, how would you go about doing early screening with a student with autism?
Yeah, that's a really good question. So we think it not necessarily needs to be, you know, excluded. So with the early bird screener that we have, because it's a game and it's very engaging and it's, you know, with the touch screen, we've actually included a number of children who were on the spectrum. And some of the teachers even said that, you know, oh, they would wish more assessments were like this because the children responded really well to this. So that is, you know, I don't want to say every child with autism will benefit from this, but I think we need to, you know, not automatically exclude them, but really think, you know, what are some of the aspects we know that lead to atypical reading, and if, you know, a child has, you know, challenges with oral language, we need to make sure we address this, and we need to make sure that we understand that some of the, you know, maybe syntax or listening comprehension issues or vocabulary issues can lead to problems with reading fluency, reading comprehension. So I wouldn't automatically exclude those, but you need to be a little bit more creative, and could use some of, you know, the screening instruments out there that are maybe more child friendly, or, you know, use more of you know, a approach where you just observe a child's oral language, or work really closely with other stakeholders like SLPs to determine some of these risk factors.
Wonderful. We have some participants who already went to see Early Bird online, and they're saying that it's not yet available in Canada. Do you have any idea of when it will be?
Yeah, I actually talked to the CEO a week ago, and I said, you know, given that you know, there is now this wonderful report out, we really need to, you know, start going north. And I think she's on it. But I would strongly encourage you to just go on the website and, you know, say, when are you coming to Canada? And I think the more, you know, people asking for it, the easier it will be to implement. Yeah, but I also want to mention, because of my conflict of interest, that there are other great screeners out there, and that you can, you know, start with those. I wouldn't just, you know, wait. I will, you know, just say, like, keep going, start, you know, looking at kids who are, you know, at risk for developing problems with reading early.
Two very important questions I have in my head right now, and I don't want to forget them. One of them is second language.
Mm-hmm.
I have a lot of immersion students, French immersion. And in one particular question, the participant said that the student gets 30% French and 60% English in their class. Now, how would you go about screening? Would you go first language or second language? And are there normed cutoffs or adjustments made in the testing to account for ELL?
Yeah, that's a really good question. Yep.
I was going to say FSL students. Yeah.
Yeah. So there's a lot of research that still needs to be done or is currently ongoing, right? So I give you one example. So we just finished a study, and we haven't looked at the results yet, where we asked the question in children who are primarily Spanish speaking. So this was a study with recent immigrants from Spanish speaking country into Boston area. And we asked, should these kids be screened in English because they will learn to read in English in Boston Public Schools, or should they be screened in Spanish? Because we want to know, as we said, their oral language history. We want to know, do they have good syntax understanding? Do they have good vocabulary in their primary language? And then see whether this best predicts reading outcome, right? Or is it a combination of both, where you want to make sure that maybe, letter sounds should be, screened in English, but then maybe oral language should be screened in their, mother or caregiver tongue. And I think there is not quite the correct answer just yet, but I think it's important to determine whether this child has a language delay or any problems with oral language in their, primary language, their mother tongue, right? Because that will then, help you to understand that if there's already problems with language in the first language, there could be a strong indicator that the upper string needs, more work. Also, it's really important to look at phonology of the different languages. So Spanish phonology is very similar to English phonology. So something like non-word repetition, you could easily do with, a child, even though he or she or they don't understand any English, right? So you give them Spanish instructions or French instructions, and then you just give them a non-word and ask them to repeat the word back to you, right? So it doesn't need a lot of like sophisticated, understanding of the instruction. That doesn't work, that works less well with like a Mandarin English combination, right? Because Mandarin has very different phonology from English. So there you might want to make sure that the child actually hears, perceives the different sounds in English first. And so that screening may be a little bit more complicated. So for now, I would not exclude those children. I would just pick a screener that gives you like 10, 12 different subtypes. And then you could see, okay, this child is actually fine in non-word repetition, but this child is really struggling with letter sounds, probably because they were never exposed to English letter sounds yet. So you can make a really individualized assessment if you pick a screener that assesses the different aspects and not just looks at, reading.
Right. Now, as you know, we're all embarking on this journey, and it's new for many of us. The question is, would you recommend that school boards, or some school boards may create their own screeners? But when you're looking at norms, when you're looking at, tell us your...
No. So no, I would not recommend. So we just developed a screener, right? And it's a lot of work. It's like 5, 6, 7 years of hard work, because you want to, have experts that know exactly what kind of items you want to put in there, right? That are appropriate. You want to make sure it's validated. You want to make sure it is reliable. It has good classification accuracy. You want to make sure it's peer reviewed. You want to make sure you're testing 1,000, 2,000 kids that are representative and follow them longitudinally. So it's a lot more work than just putting your favorite non-words in the list, or testing some of the letter sounds that you think may be important, right? So there's people whose job it is to create these screeners, and there's many great screeners out there, and some of them are fun, and some of them are already bilingual. So I feel like I would not recommend at all to have school boards or teachers or educators create their own screeners.
Wonderful. We have a question about epilepsy, and you're the right person to ask. Would screening students with Rolandic epilepsy have us change how we screen?
So, it would really depend on the individual child, but I think it would be really important and could give really important insights on where are the strengths and weaknesses in this particular child, right? So there could be a child who, may look like, he or she or they having, more problems with the mechanics, but it could be that the underlying problem lies more in the oral language, right? So, and vice versa. Or you can, using a good screener can really help you to say, okay, here the child reached, his or her their milestones, and in these areas not quite yet. So I feel like it makes it much more targeted, and it doesn't really matter what other problems or challenges the child is facing, because you are more taking an individualized approach. But then in the response to screening follow-up, you can then group children, right? You could say, okay, I'm going to I have a group of children who really struggle with letter sounds, so I'm going to have these kids work on letter sounds, versus another group, they're like, oh, their letter sound seems to be fine, but they seem to struggle with something else, so you can focus on this.
Yes. Mm-hmm. Okay, another great question. Unfortunately, in Ontario, we've had a wait to fail approach, as you mentioned. All right. And students aren't being offered psychoeducational assessments until grade 3, the age of 8, mostly. It's often 9 and 10 because of wait lists. Mm-hmm. And they're denied service until those ages. Mm-hmm. All right. And so screening is lovely. We're really happy that that's being introduced in JK and SK in grade 1 and grade 2 now. But would you say there's an essential age where there should be a psychoeducational assessment?
For every single child?
Not at all. No, for presenting issues. Yeah.
So I think it really needs this mindset shift, right? So I think, if a child starts the first day of kindergarten with a significant language delay, and the older brother was just diagnosed with dyslexia in 4th grade, and the mother is struggling with reading, and the child may be from a background where there may be less rich oral language, I think this child needs to really, be looked at, and maybe, after a screening looked at using like a more diagnostic approach, right? But not every child needs this. So I feel like, it really depends on the individual child, but, there will definitely be children that, will benefit and need, early diagnostic evaluations.
Good. Thank you very much. And now I think Alicia is going to take over to say a formal thank you to you. One person did ask for your opinion on the Dibbles and the Ames web.
Yeah, so I'm not, usually what I do is I'm not commenting on any specific screeners, but I highly recommend that you go to these lists. So you can right now go to NCII and go to the tools chart and go to type in Dibbles and type in Ames web, and then you could compare those directly. You can also compare those using the big screener list that we have on our website. You just need to wait a week or two until the maintenance is over. And then you can see exactly how this compares to each other. What's really important is that one screener for district A may not be the optimal screener for district B, right? So that's the tricky here. So it's not like, oh, we all use the same blood test to screen for high cholesterol. It's a little bit different here, where it's more like you need a different assay, for one group of individuals versus another group of individuals. So it needs some work, but developing guidelines maybe on the state level or on the Ontario level will be helpful, similar, and that's why I mentioned the Massachusetts guidelines, and there's other states who have similar guidelines that could be as a template to like, this is how it should look like. And then each state here in the US has a list of recommended screeners. So you could narrow it down to like 5-6 screeners that work for the curriculum, but also for maybe the children representative in the state or in the district, and then go from there.
Great. Thank you so much. Alicia's going to take over now. All right.
Thank you.
Thank you, Joanne, and thank you so much, Dr. Gaab, for joining us today. I know that the chat was lively and we had such good questions. So your time and your expertise is so very much appreciated. Thank you so much for joining us.
Yeah, if any questions are unanswered, you could email at gablab at gse.harvard.edu. I can put it in the chat, and then we usually try to answer within 10 days questions, but we always answer all the questions. So if you have any outstanding questions, we're happy to answer them. You just have to email us and be a little bit patient.
Good. We'll look in the chat for that. Thank you so much.
Thank you. And thank you, everyone. We're going to go to another short break. We will be resuming at 12:30. So thank you again, Dr. Gaab, and we will see everyone at 12:30. I will be starting another short video with some more surprises.